Friendly greetings from Yale University to the World Social Forum in Tunis. My name is Thomas Pogge. I was asked to talk to you briefly for about 10 minutes about the TRIPS agreement, which you will be discussing there. As you all know, the TRIPS agreement was part of the World Trade Organization treaty, which was concluded in the mid-1990s. And as far as medicines are concerned, the main provisions of the TRIPS agreement are that every WTO member state shall grant 20-year product patents for pharmaceutical innovations. Product patents contrast with process patents, which protect a certain way of making a medicine, but the TRIPS agreement prescribes product patents. That means where the molecule is protected and nobody else can manufacture it in any way or sell it. These patents have a duration of minimally 20 years, and that means that for the 20 years from the point of the application for a patent, the medicine cannot be sold or produced by anyone other than the innovator without the innovator's permission. Now that system has various kinds of drawbacks. One drawback is that during the time that medicines are still under patent, the pharmaceutical innovator will tend to sell the product at the profit maximizing price, which in a world of great inequalities tends to be quite high. The result is that a large number of human beings lack access to these advanced medicines and have to wait until the medicine comes off patent. A second problem is that the diseases concentrated among the poor are not lucrative targets of pharmaceutical research and development. The reason for that is obvious. When you have a new remedy for such a disease, you face a Hobson's choice. Either you can sell it at the usual very high markup, 50 times, 100 times the cost of manufacture, but then you will have no customers because the patients who have the disease are poor. Or you can sell it at a price that the patients can afford, at which time you don't have much of a markup. So pharmaceutical companies can make much more money by researching remedies against relatively trivial diseases of the rich, rather than researching very serious diseases of the poor. The third important problem is that there's a great deal of waste in the system. You can quickly see that by thinking about how much money the world at large is spending on medicines, namely roughly $1 trillion per year these days. That's $1,000 billion. And how much of that money actually goes back into research and development and manufacture of medicines. That's only a small fraction. Most of that money really goes for wasteful activities, such as litigation of brand name companies against one another and against generic companies, for advertising, where companies are simply competing for market share, efforts that are essentially canceling each other out. And a great deal of waste also is involved in deadweight losses. Deadweight losses arise when there is a great gap between the price and the cost of a medicine, and many profitable sales, profitable for the company, cannot be consummated, because if a company, for example, sells its product at the optimal price of $100, if that's the optimal price, and the cost is $10, there are many sales that would be theoretically profitable for the company between 100 and 10 that cannot be consummated, because as soon as the company sells for below $100 to some people, the people who are now paying 100 will no longer want to pay 100. So these deadweight losses are also in the order of about $200 billion a year, and they add to the cost and waste of the present system. Now, the TRIPS agreement is difficult to change, and it also has some advantages in terms of incentivizing pharmaceutical innovation. And so the question is, isn't there a way that we can complement the TRIPS regime so as to overcome some of its drawbacks? Here's an idea about how that can happen. We are proposing the creation of what we call the Health Impact Fund. The Health Impact Fund would be jointly supported by many governments, contributing perhaps 0.03% of their gross national income each, That would collect somewhere in the order of perhaps $6 billion, even if only a third of all countries participate. And these $6 billion annually would be used to reward pharmaceutical innovations. This is how it would work. Every pharmaceutical company would have the option, no obligation, to register any new medicine that it brings to the market with the Health Impact Fund. If the medicine is registered, the medicine will receive rewards for the first 10 years that it is on the market, and these rewards will be proportioned to the health impact that the medicine achieves in the world. Each year then, all the registered medicines will be evaluated for health impact, and the entire $6 billion reward money will be divided among the registered medicines in proportion to the health impact that each of them achieves. Medicines would come onto the Health Impact Fund, stay on it for 10 years, and then drop off. We estimate that at the rate of $6 billion a year, we will attract roughly 20 to 25 medicines, which means that about 2 medicines or 3 would come on each year, and 2 or 3 would drop off each year. Now, it's a condition of registration that the innovator voluntarily gives up the usual reward that medicines attract, namely that markup power protected by a patent. So as a condition of registering with the Health Impact Fund and accepting the health impact rewards, the company would have to promise to sell the medicine at cost. At cost, that means that we would ask the company to put the production of the medicine out for tender among competing generic manufacturers, and the cheapest reliable manufacturer, or maybe the 2 cheapest, would get the contract, produce the medicine at the promised low price, and the innovator would then sell it onward to the wholesalers at that same low price. The innovator would make no money at all on the production or sale of the medicine, and would make all its money as a reward for its research and development efforts on the health impact rewards that it would receive. Now, this system has a bunch of advantages. First and foremost, of course, medicines under the Health Impact Fund scheme would be cheap from day one. Poor people would have access. They would not have to wait for the end of the patent period, because medicines would be sold from the first day at the cost of manufacture. Secondly, the great diseases of the poor would become lucrative targets of pharmaceutical R&D. There are several so-called neglected diseases that are concentrated among the poor, which do a lot of damage and attract very little research and development efforts. These diseases are the low-hanging fruits, which in the early years of the Health Impact Fund would attract a great deal of effort. Thirdly, much of the waste that I talked about earlier would be history, because nobody would really want to sue companies for the right to manufacture a drug if the drug is already selling at a very low price. Advertising, again, competing advertising would not occur under the Health Impact Fund, but there would be advertising aimed at finding or informing patients who may not know that this new medicine exists, and that, of course, is good advertising that we want. Deadweight losses would completely disappear because there would be no gap between the price of the medicine and the cost of the medicine. And there would be one further important bonus. That is that for the first time, pharmaceutical companies would have really powerful incentives to care about what happens to their product after it crosses the counter, after it reaches the patient. Namely, will the product be correctly taken? Will patients take the whole course? Will they take the medicines correctly to optimal effect? All these matters will be important for the innovator, because the innovator is now paid for health impact. And health impact is not achieved simply by selling the medicine, but only if the medicine is actually taken correctly for the prescribed number of days at the prescribed hours, with meals or without, as the case may be. And only if that health impact is achieved will the innovator reap the full reward. Now, we think that this Health Impact Fund system, relatively cheap at $6 billion, remember the world is spending about $1 trillion now very much more on medicines. So a relatively cheap complement to the TRIPS regime would make a very considerable difference to how much health impact we get for all the money that we spend on medicines. Now, of course, there are many questions and many reasons to be skeptical. For example, many people have said, is it really possible to measure accurately the health impact that medicines have in the world? We think that is possible through methods of statistical sampling, where we follow a randomly selected set of packages down the pipeline to the end user. But what we need to do before we put the system into place is obviously we need to do pilots. We need to do pilots with particular medicines in a particular jurisdiction, for example, a province or a smaller country, and see how the system works in practice. And that is something that I ask you all to support us in trying to get small amounts of money, maybe $2 million, $1 million, to do pilots on medicines where we would go into a particular jurisdiction, ask an innovator to give us permission to sell a medicine at cost, and then reward the innovator in proportion to the health impact that this medicine achieves. A pilot would help us do at least two things. It would help us refine our measurement method and show to the world that we can really accurately and reliably measure the health impact that the introduction of a new medicine achieves in a jurisdiction. And secondly, it would also show how innovators will introduce their medicine differently if they are rewarded according to health impact rather than simply for sales. What innovators will do in such a pilot is they will make an effort to reach the patients who can benefit the most and to instruct these patients and their doctors and nurses appropriately so that these medicines will really have their full optimal health impact. Thank you very much for your attention.